Okay, Assalamualaikum warahmatullahi wabarakatuh and good morning. I bid to Prof. Khaldun, our EMSS advisor, doctors, professional and fellow participants. I hope everyone is in the pink of health and ready for a wonderful day of learning here at the Emergency Medicine Seminar Series, EMSS 2023. My name is Amirul Adib bin Ahmad Zakhi, Medical Officer of Hospital Chancellor Tuanku Muhriz, HCTM of Malaysia. I'm honored to be the moderator for today's event. For your information, today is the third and the final week of this seminar series, and the theme for today is clinical toxinology. I hope we as healthcare providers will embrace the golden opportunity to actively participate, update ourselves with the latest advances, and explore the challenges in this toxinology field. Thus, ultimately, we can provide the best care for the patient. A quick recap of today's tentative. We will kickstart our day with an opening speech by Prof. Khaldun, our EMSS advisor, followed by 4 presentations by 4 distinguished panelists. Between the second and the third speakers, there will be a 15-minute break. After the fourth speech, there will be a forum session involving all the speakers. Subsequently, followed by the most awaited segment, Kahoot, where a prize is up for grab. And lastly, we will close to the event with a closing speech by our program director, Dr. Nava. First, let us take a moment to express our gratitude to the organizers, sponsors, and the committees for making this program a reality. Without their dedication and support to the event would not be possible. Here are some friendly housekeeping reminders. First, kindly post your question in the Q&A section on the Zoom platform. Second, question will be answered cumulatively during the forum session. Third, never spam irrelevant messages in the chat box. Fourth, QR code for CPD point and feedback form will be provided at the end of the event. And lastly, e-certificate will be provided to your registered email within days after completing the feedback form. Dear participant, Prof. Khaldun is a leading figure in this clinical toxinology. He is the president of Malaysian Society on Toxinology, founding members of Remote Envenomation Consultancy Services, better known as REX, and Asian Marine Animal and Snake Envenomation Management, AMSAN. He also produced a number of academic publications throughout the years. Prof, kindly give your opening speech.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Amirul. This is the last leg of our EMSS 2023. This is actually our 5th run of EMSS. I think the first one was in 2018 or 19, and then we were hit by COVID, and we had to take a 1-year break before we restart the program again during the pandemic period. And that is where I believe our foresight in terms of education, spreading information that we did before COVID in terms of using webinars were fruitful, so that we could actually go into the mode of so-called international engagement with our friends around the region much more easily. We don't have to travel in person to conduct a webinar, to conduct a seminar or training programs. So obviously it's not for everything that we do, but I believe there are certain things we have to look forward. We have to, push forward or move forward in terms of education method. And this is one of it in terms of sharing information. We have a lot of new discoveries in this area of clinical toxinology. We see our friends from all over ASEAN and also Asia that has already taken up the challenge of improving care to patient. And today we have a good friend of mine, from Taiwan. We did a few research with regards to clinical toxinology, and we published the results. So this is very important, I think, in terms of networking. This is your opportunity to liaise with many experts in the region, so that actually we can combine our efforts. So for example, that I give an example with the POCUS and also what we call POLS protocol now. Started in Malaysia, and we just did kind of observational report about it, and we feel that it worked. And our colleagues, we presented to our colleagues in Taiwan, and they take up the challenge to conduct the study with their population, and it shows a positive outcome of what we have been practicing all these years. So that is a very reassuring, how should I say, way of saying that you are actually doing something good to our patient. Okay, so I can't stress more that as young doctors, young specialists, you're going to become the referral point for many others in the emergency department. So in cases like this, in terms of clinical toxinology, I have to say that it's not for everybody. It's everybody is not the same level of understanding in terms of the knowledge wise. There's always a gap, and that's where Rex comes in. And we are always here for you, no matter if you are a specialist or not. You are still available to the collective expert that we have in Malaysia and also in the region. So with that, I hope everyone here will have a good time listening to our esteemed speakers from all over ASEAN and also Asia. And I would like to take this opportunity as well, being this being the last EMSS for 2023, is to say thank you to all the committee members. You have done a great job. I really am proud of you guys. We start from scratch in the past. We did use some templates, but once we have something which is regularly occurring, we can actually do things much easier. So I look forward to today's event, and all the best to all speakers. All the best to all participants as well. Good luck in the Kahoot quiz. Don't miss that. We have good gifts or prize to win, to be won at the end. So with that, thank you, and wishing you all the best.
Thank you, Prof, for the wonderful and inspiring speech. A bit of a down memory lane down just now. So let us kickstart our day. Dr. Hassan Adam is here to share his wisdom and experience with us. He completed his postgraduate emergency medicine study at University Malaya, UM, in 2012, and then pursued his fellowship in toxicology in India back in 2018. Currently, he serves as an emergency physician at Lipas Hospital, Brunei. He will deliver his speech entitled The Sleepy Boy. Dear doctor, the screen is yours.
Okay, Assalamu alaikum and good morning, everyone. Thank you for having me here today in this session, and thank you for all of you of being here. And thank you to Prof. Khaldun for this kind of brilliant idea of sharing knowledge beyond the borders without traveling or going anywhere. I think nowadays we are in the digital era, so things for sure much easier compared to a few years ago. So thank you all. Let's start with this presentation. This is about a boy. Just to give you a hint, this is not kind of sad story. This is like kind of sour sweet story. So let's start. Okay. What do we expect? I just want to try to outline how we progress into this presentation. First, we have the case presentation, followed by some diagnosis dilemma and what we have done initially in our emergency department. Then we talk about kind of general info about the snakes, but we straight away zoom in into the snake bite and specifically about trade. And then we might talk a bit in depth about the snake venoms, specifically again about the trades, and then the antivenoms, and when we're going to give it, and how we're going to give it, and how we can manage the expected side effects of it. And by the end of the presentation, we will see what was the outcome of this little sleepy school boy. So let's start. This is a real case was seen 2 years ago, probably around 6 years ago in our department. There was a 5-year-old boy. He was playing in front of their house with the others of his siblings that morning. And if I remember well, that was Friday morning. So there was no any school on Friday in Brunei. So by noontime, he was noted to be a bit weak. Probably initially the family thought he might just be playful and he get a bit weak and he just need to take some rest. But obviously by that noontime, maybe around 12-ish, they felt a bit concerned. So that's why they have brought him to our emergency department. Initially when he was brought in, there was no history of injury was given. And there was no any history suggestive of a seizure was given, and there was no any history of possible ingestion of any sort of hazardous material, probably is like liquid, whatever it is. No such history was given. So that was the history. So we have the boy and we have his father. That's the only one from his family who brought him to the hospital. Then we just put him in our P2, just to give you a bit of idea about our ED layout in the PAS hospital. We have a pediatric department and emergency pediatric and emergency adults, but both of them are side by side, so you can cross from one department to another. So we put him at the P2. Initial assessment, he was afebrile, lethargic looking, not dyspneic or tachypneic, not in any shortness of breath. He's not, he wasn't looked in pain, and he was fairly hydrated. So what I meant to say is the initial assessment is like just someone lethargic, not much of other issues. Then on clinical examination, we noted that his BCS was around 14. If you look into it, still he was obeying command. He keeps his eyes open spontaneously. The only issue here is when he speaks, he's like kind of a bit sluggish. That's initially. Also, we have noted he was having a mild ptosis, but pupils were equal. No fever. Vitally seems to be okay in terms of blood pressure-wise and pulses. We did his digestive sugar, it was 6.2. Saturation at that time was 96 on room air and chest was clear. And there's no obvious external injury. So we have this boy fairly okay, apart from that GCS of 14 and that kind of lethargy and a bit of kind of lowish, let's say, a bit of lowish SATS on room air of 96. So we proceed with a fairly standard approach. We did start to take some blood samples. Part of that was VBG. As you can see, the VBG I just brought in 4 components because this is like kind of important negatives. So no acidosis, potassium looks okay, and if I remember well, his sodium on VBD was okay. So based on this, let me just go back on the slide. Based on this presentation and on this initial assessment and the clinical findings, we are like kind of puzzled what was going on with this young boy. Because we don't have much of history to make sense out of it, because only the father was there. And that's the story that he was given to us. So we start thinking probably this young boy, he might have accidentally drink something probably, and that's might explain why he has this some sort of drowsiness and this some sort of like a bit of ptosis. We are not sure, honestly. Then while we are getting all these routine investigations and observations, about 30 minutes later, we noted that his GCS started to drop. So GCS of 10, and if you look into it, still he's obeying command. He was obeying command. He can lift all 4 limbs. So the main issue was his E and his V. Blood pressure is okay, but he became tachycardic, a bit tachypneic, and we have to maintain the saturation of 100% on high flow mass oxygen. And most importantly, he was start drooling. Okay, so things getting a bit freaky here. Initially, we just thought it could be just it might be mild to moderate presentation of some sort of like intoxicating indigestion we don't know of. But now the CSS started to drop. Saturation have to be optimized with high flow mass oxygen, and most importantly, it started growing. So based on this finding, again, we kind of revisited the history, and still we have only the father was there, and he don't have much of history details to rescue us. So we thought, okay, let's get into this boy management, and let's go classical. What I mean by that, let's go ABCD management, while we are looking around for some probably history, probably some sort of clinical findings, which might give us a clue for definitive diagnosis. So we decided, and we said, okay, let's get him intubated. So while we are planning for our intubation, of course, we need to prepare, and we need to set up all the things. And this was our rescuer. And from here, I would say thank you to Professor Singh. He was our consultant on that day at the PAS hospital. Currently, he is enjoying his life in India. And yesterday or the day before, I was in touch with him, and he's enjoying his life there. So greetings, Prof, from here, and thank you for help. So he was the consultant in charge that day. So while we are doing all this, suddenly he just came in, and we have taught him the story. We have this boy came with this history. This is our finding, and this is what we have now. So what he has done was quite astonishing, at least to me. He just said, "Can you please take off all the clothing for this young boy, and let's see." So we start looking into each other. Why Professor want to take all the shirt and long pants off of this young boy? So anyway, we just off the shirt, we off the pants, and we just put some drape on him, and he start looking from the toe up. And to our surprise, we found 2 small faint let's say this, very faint. Unless you're looking for it, you will not find it. Two small faint dots at the dorsum of his foot. And at that moment, he said, let's treat this boy as Snakebite. To be honest with you, at that point of time, I was a bit skeptical. Why this one has to be Snakebite? Because, first of all, I felt that Snakebite has to be big to wounds, bleeding, or probably some local reactions supposed to be there, or probably the child himself might experience some sort of pain. Anyway, none of those. So we say, okay, fine. So what we will do, we proceed with our incubation. He was get intubated, and luckily we have antivenom in our department, and we have this polyvalent antivenom. We gave him 3 vials of antivenoms. We run it in 1 hour infusion. By the time the child was intubated, and the pediatric ICU, they were already there. So child intubated, given antivenom, is still running. I will come in details later on this antivenom neuropolyvalent. On top of that, we gave him some hydrochlorophenoramine, chlorophenoramine beside hydrocortisone. And we gave some atropine. And of course, we kept him on normal saline hydration. That is about that young boy. So the picture here basically shows us, shows to you, this is a neuropolyvalent that we have back then, and still we have it. This is for kind of 4 big Cobra, King Cobra branded crates and Malayan crate. So this is exact antivenom that we have it right now in our department. This is just to show you the manufacturer recommendation for how to give that specific antivenom. We come to that later on. Later on, few other family members come from home, of course, and then we have more history. So according to them, while they were looking out, they found snake. They have planks of wood just piled outside in front of their house. And when they looked into it, probably from the beginning they were suspicious. So they found there is a snake. So they call what we call here Bumba. So they attend to the house and they took the snake away. All right, we might, and the snake was kind of this. This is just a reference, but exactly, this is the kind of snake that they have found in front of the house, in between the wood planks. Now, the young boy was, as I have said, intubated and was sent to a pediatric ICU. So now, let's leave our intubated child there and let's dive into a few other things. To be specific, I just want to say a few general information about the snakes and the snake classification. I'm sure all of you knows and remember very well the classification of the snakes, but this is just a reminder. But before that, I just want to share with you this general information about the snakes. So worldwide, we have around 3,000 known snake species. There's a lot of them. Out of these 3,000, we have around 300 are venomous. In this Southeast Asia, and to be more specific, in India, there were around 200 species of snake were identified. Out of these 200, around 50 species are venomous. Of course, this is a Southeast Asia. If those kind of species identified in India, I'm sure these species are going to be all over the place. But probably in some areas, we might not identify them yet. But doesn't mean that they might not be there. So fair enough to say, probably right now, we have one of those 50 species wandering around our houses, or the near bushes around our houses. So, of course, bites are environmental hazards. More exposure to the environment, for example, farming or construction in the jungles, or those who might have some hobby of hiking, they're going to be exposed or high risk for those kind of environmental hazards. Of course, bites are a medical emergency, but the good thing is not all bites require antivenoms at all times. One more thing, absence of marks may not preclude bites. What do you mean by that? If you can't find bite marks in your patient, but the patient shows signs and symptoms saying that this is it to be a bite, that it might be a bite, despite you didn't find any marks. Okay, so this is the classical classification of the snakes, as I have said. In general, poisonous snakes belong to three families: Elapidae, Eurapidae, and Hydropidae. For today, we'll be more focused on Elapidae, which were mostly neurotoxic. And within that Elapidae, we have other subgroups. There are crates, there are cobras, and a few others. But again, we need more focus on crates. So, crates in general, crates belong to Bangarus species. As you can see the picture down there, crates sometimes might be quite docile, not that much aggressive, and always ready to bite kind of snake. Sometimes I have heard, I haven't seen, but I have heard this in some areas they might be used as a pet. I'm not sure of that, but for sure, I'm not going to be the one who uses this kind of snake as a pet. Anyway, crates belong to Bangarus, and within this Bangarus family, we have around 16 species in Southeast Asia. Again, that's a lot numbers of snakes to know of. But I have to mention few interesting species here belong to Bangarus. Of course, for sure, we have the Malayan or the blue crates. They call it Bangarus candidus. These Bangarus candidus, it has certain characteristics which might dictate how its bite might be and what the symptoms progression might be. So one of the characteristics is the fangs are short and quite thin, not as long as the big gigantic fang of, say, for example, king cobra. Interestingly, this Malayan crate in some areas, probably within the Southeast Asia, they call it as five-step snake. I'm not sure how accurate that it is, but to me, that implies that this snake, it might be deadly, or for sure deadly. That means if someone bitten by this snake, he might just go for a few steps and he will drop down dead. That is quite awful. Again, those Bangarus, those Bangarus, there's other species I want to give as an example. As I have said, in this Southeast Asia, we have around 16 of them. But I will be more focused on crate, but I'm just going to give you a few examples. Probably I find it quite fascinating. One of them is, this is a Malayan crate, as I have said. This is our Malayan crate. Let me just throw this one away a bit. This is our Malayan crate. As you can see here, it's like just banded black and white. I know a lot of other species outside there looks the same. But when it comes to snake recognition, for sure you need that kind of expert eyes to differentiate, which might not be easy for someone who just walk by. So this is just, I just want to show you here the difference between the fangs. This is the king cobra, the topmost. As you can see there, the fangs is like just a gigantic, big, sharp fangs. That's a cobra. So do you expect those kind of bite will be just small, very faint looking kind of bite marks? No. These fangs will leave definitely very obvious mark whenever there is a bite. But if you look into the down picture there, this is like kind of, I don't think that whether you can see the fangs of this Malayan crate, barely protruding out of its upper jaw. It's quite short and it's quite thin. So that's why the bite, it might be barely traceable. That's the difference between these two fangs, cobra fangs and the Malayan crate. So having that kind of very small and thin fangs, this, as I have said, will dictate how the bites and the symptoms of Malayan crate will be perceived. First of all, totally it might be painless. So someone might be bitten by the Malayan crate, but he or she might not be aware that he was bitten. This is what, because there will be no pain. Number two, because the fangs were quite small and thin, there might not be any bleed at all. Number three, there might not be any local reaction to that bite. And because of this, the fangs are short and thin. The percentage of dry bite with the Malayan crate, it might be a bit higher compared to those with the gigantic fangs. I have no statistics to tell you per se, but based on this characteristic, we do expect that the dry bite might be a bit higher compared to others. This is about the facts. As I have said, the bangaroos, they have 16 different species here in Southeast Asia. Malayan crate is one of them, but as I have promised, I will show you a few others. These types of crates. Have a look into this beautiful looking snake, if I have to say that. But of course, still this is a deadly snake. This is a red-headed crate. This is a red-headed crate. The third one, this is the sin crate. Yes, if you look into it, more or less, it looks like just Malayan crate, but for sure, for those who are expert in snakes, they can spot it easily. Why I mentioned about this sin crate, because this sin crate can survive in snow areas. So if you happen to go to, for example, the Himalaya or those hilly, snowy area, probably part of the Pakistan, part of India or Afghanistan, and you're interested to go there for hiking or whatever it is, please remember, yes, this is snowy, but it's still the crate, it might be hiding somewhere. So you have to be very careful. Being in snowy environment, that doesn't mean that there will not be any others sharing you the same place, specifically the same trait. The third one, this is a red river trait, and to be specific, they call it Bangarus Slowniski. Unfortunately, this red river trait linked to a very sad story. That story was around 20 years ago. There's a very enthusiastic hepatologist, Dr. Joseph Slowniski. He was at the deep jungle of Myanmar, looking into all these snakes and all these creatures inside the jungle, within the jungle. And of course, he has his team. Unfortunately, he has spotted this red river trait. And to everyone's surprise, he might have misidentified that snake, and he just held it up, assuming that this is one of those non-poisonous snakes. And unfortunately, he was eaten. And that was at the jungle, at the deep jungle of the Myanmar. Unfortunately, because of that, he lost his life. Yes, it was a very sad story, but unfortunately, that story was linked to this river trait. All right, so that's the few species of Bangarus. So now I might just need to talk a bit about the snake venom in general. As we are always saying, it's not venoms are a combination of every awful thing that you might think about. But to put that in a kind of objective way, it's like a combination of proteins and enzymes, metalloproteins, procoagulants, phospholipase A2, and pre and post synaptic neurotoxins, and few others. Not few, probably more others. The issue with this composition, this is like kind of a deadly composition. Why I'm saying a deadly composition? These kind of components, they might act synergistically and potentiating each other's effect. So that's why for those venomous snake to have these whole lots of components within their venoms, it might synergize each other, and the end result might be catastrophic whenever there was or there is a bite. So to be more specific, I just want to say a few things about the crate and neurotoxin. We do know that crates belong to neurotoxin kind of snakes. In the venoms of the crates, mainly predominantly there are neurotoxins, and to be more specific, there are beta bangarotoxin, which is similar to the botulinum, and also they have phospholipase A. If you look into this beta bangarus or beta bangarotoxin and phospholipase A, they are predominantly presynaptic neurotoxins. Yes, sometimes you might have some postsynaptic neurotoxin within the crate venom, but predominantly it is presynaptic. Why this is important? Because it might have effects on the what kind of syndrome you might going to expect whenever you have someone with a crate inflammation. Not only that, having that predominance of presynaptic neurotoxins, it might dictate what kind of medication you will give, and what other medication it might not be beneficial when you are dealing with or treating your patient. So These beta bangarotoxin and phospholipase A, they are all released. They are all get access to neuromuscular junction, and this will lead to massive, let's say that, massive release of acetylcholine at the neuromuscular junction. And as you all know, that massive release of neurotoxin at the neuromuscular junction, it will manifest it into all the signs and symptoms of acetylcholine surge. All right. Then, because of that massive release, the neuromuscular junction, it might be totally obtunded. Not only that, because of the presence of the phospholipase A2, this neurotoxin will interfere with your nerve endings cytoplasm cells. And this will lead to the damage of the neuron terminals. So if the neuron terminals were damaged, that means there might not be furthermore endocytosis of your all spillover acetylcholine. And because of that, there is not going to be any more release of acetylcholine vesicles from the nerve terminals. So having those kind of combination, that neuromuscular junction will just be non-functional. All right. So that is the very dominant pathophysiology of Krebs neurotoxin. It will destroy your neuromuscular junction. So to get neuromuscular junction back to the function again, has to regenerate it. And to have a new neuromuscular junction, it will take time. So probably weeks. So in that case, if you have a patient with massive or severe credit envenomation, he or she might stay in ventilation for fairly a long time, but that might not be the case in all scenarios. All right, so now we know that the crate has neurotoxin, and it's toxin mainly targeting the neuromuscular junction. So now let's talk about the antivenom. In general, antivenom, there are immunoglobulin antibodies, and we all know how they kind of purify. And those antivenoms, it could be poly or it could be monovalent. What I mean by monovalent, that one antivenom to one specific snake. But what we have right now, and I think in some other areas, we have the polyvalent, because polyvalent is like more cost effective and more practical. And of course, different area, they have their own different snakes. So to have one specific antivenom for one specific snake, that's kind of a waste. Yes, it might be more effective, but as I have said, it might be costly. For the time being, it seems to be everyone is like just goes towards the polyvalent because of this practicality, because of these cost issues. So now we have a bite and we have an antivenom. Shall we give the antivenom for everyone who has a bite? Of course. So now we will talk about the indication of antivenom. And to be more specific, here I will talk about the crates, neurotoxins. So to start with, straightforward, if you have a patient with a bite, or you assume there is a bite, you have to look for an envenomation. Is your patient has signs and symptoms indicate he or she is envenomated? If that's the case, just go ahead and give the antivenom. So briefly, I will mention here what are the signs and symptoms of this envenomation. Again, this is about the neurotoxic traits. Ptosis, drowsiness, drooling, speech difficulties, shortness of breath, and paralysis. And sometimes you might have an unexplained abdominal pain, specifically in pediatric population, and or you might find a new unexplained hypertension for someone who has no any high blood pressure before. So that is the sign and symptoms which might indicate your patient is in an envenomation or envenomated, and the antivenom should be given. So how we give it? Very safe to say, just follow your antivenom manufacturer recommendation. And of course, you need to look into your local SOPs. But in general, the sooner you give the antivenom, the better going to be the outcome. But before you give the antivenom, please remember these antivenoms, they are kind of has allergy. That means your patient might end up into some sort of allergy, ranging from mild itch to catastrophic anaphylactic shock. And because of that, please, before you start giving your antivenoms, keep your crash cart within your arm reach. And that crash cart loaded with all these good drugs, adrenaline, hydrocort, ketones, lots of salines if needed. Of course, as I have said, you need to follow your manufacturer recommendation and your local SOP. But for us, since we use this neuropolyvalent, and according to our SOP and according to our manufacturer recommendation, we can start with 6 to 10 vials and should be given infusion within 1 hour time. And these doses can be repeated according to manufacturer, again, can be repeated between 30 to 6 hours if no response. What I meant to say is when to give, when to repeat, it will depend on the response to the previous dose of antivenom. But to start with, you can start with 6 to 10 vials as first dose. There's one good concept here. Recently, I think there is a few studies suggesting that there is something called paraspecific neutralization activity. What they mean by that, the close related species of snakes, they might respond to more or less similar antivenoms. So, for example, some of the bangaros might respond well to these polyvalent, though they might not be listed into the manufacturer's targeted snake bites. That's what you mean by paraspecific neutralization activity. Okay, we just try to be on time. So what are the side effects of these antivenoms? Of course, the big one is your anaphylactic shock. This is, it might be very early as within the first few minutes of the infusion. And for the management of the anaphylactic shock, we just manage classically. Again, we have intermediate side effects like pyrogen reactions. And later on, we might have a serum sickness-like reactions. What we are much concerned about right now is the early anaphylactic shock. Whenever you have a patient with anaphylactic shock because of the antivenom infusion, what you need to do, you just halt the antivenom infusion, treat the anaphylactic shock classically as any other anaphylactic shock, and then back to your infusion. Having said that, that means there is no an absolute contraindication for the antivenoms whenever there is an envenomation. Yes, anaphylactic shock might happen, but yet you need to treat the anaphylactic shock and back up again to continue your antivenoms. But remember, antivenom is not a silver bullet. What I mean by that is, if someone came, say for example, for this young boy, if we just gave the antivenom, do you expect that the antivenom will reverse all these presenting symptoms and signs on the spot? For sure, no. And because of that, we need to have more other sort of management strategies to buy time for your patient. And to buy time for your patient, you need to have optimal supportive care. Number two, assure your patients and communicate with the family, because this is like a kind of very agonizing situation. The family will be not sure what might be the outcome, and they are just vague about it. So we need to talk to the family, and if our patient is still there, he's not intubated, so we need to assure him, because sometimes bites itself is quite frightening for the patient. The other things, of course, timely address other ABCDE related issues. Now, we have said a few things about the crate. And earlier on, we start with our young boy. As I have said, he was intubated and he was sent to pediatric ICU. So now, what was happened with him? He was extubated 6 hours later while he was in pediatric ICU. 2 days later, he was downgraded to the pediatric general ward. 3 days later, he was discharged home well and walking. He was discharged on paracetamol and augmentin. Why augmentin? They just kept a very low threshold to treat him for very minimal local reactions, just kind of very minimal cellulitis. And he was reviewed later on, a week later, and he was well. Just to say a few things about the prognosis. Whenever there is a venomous bite, prognosis depends on lots of things. But here we just mentioned a few of them, few important points here. Early recognition and optimal management is a key. So that's why please, wherever you are, don't hesitate to contact Rex. And I think Rex here will be so much handy. Here in Brunei, for sure, I don't have someone like Prof. Khalid here physically, but I'm quite assured that at any time I can just pick the phone and I will get everything done from here. So thank you again, Prof. Khalil, and those who allow you for that Rex concept. Second point, time to seek treatment. The earlier the patient seek the treatment, the better might be the prognosis. Of course, the availability of antivenoms and the accessibility of the critical care services. As we have said earlier, for that Joseph Slowinski, if that bite was in somewhere where the critical care was available and antivenom was available, he might not have died, but that was just very unfortunate. The other points, site of bites and the size of the victims also make a difference in terms of prognosis. And then physical activity after the bites also might play a role. Because if someone was bitten and he just keep on walking around, that might facilitate the distribution of the venoms all over the body and in a more faster fashion compared to someone who has immediate immobilization after the bite and he or she shifted to the medical facility. So based on this, or based on that case we have encountered a few years ago. There's a lot of lessons learned, at least from our side. One of them is addressing ABCD alone might not be enough at all times. So that's why, yes, you address the ABCD, buying the time for a patient, but you need that antivenoms whenever there is an infection. Keep high index of suspicion for a possible buy. If you haven't seen any fangs or marks or whatever it is, and you feel the syndromic picture fits into snake bites or so, please keep low threshold for that suspicion and try to confirm as much as you can, so the patient might get the antivenoms in a timely fashion manner. And whenever there is a history lag or lags, go syndromic. For that boy, if you have the family members from the get-go and everyone just gave us the straightforward story that this boy was bitten by a snake, we should go straight for antivenoms, right? Because we don't have anyone else other than a father, and the father doesn't have much of a history. So in these kind of scenarios, you need to look into a clinical scenarios, and you try to go about it in a kind of a syndromic approach. And if you go that way, probably you will save your patient. And now, thank you so much. And that's the end of my presentation. And thank you.
Huge thanks to Dr. Hassan for sharing his expertise with us. Few other key takeaway messages from Dr. Hassan's presentation are the importance of having a broad list of differential diagnoses in approaching our patient, especially in pediatric population. Second, the ability to pick up telltale signs in treating our patient, such as in this case, ptosis and bite mark. Dear participant, kindly give 200% attention. At the end of the day, we will have a Kahoot session. The questions are based on the presentation. Ladies and gentlemen, it is now time to turn our full attention to our next renowned speaker, Dr. Cheng Ho, an attending physician from Tri-Service General Hospital, Taiwan. His experience in toxinology encompasses Adelaide Toxinology Course 2017, Asian Marine Animal and Snake Envenomation 2018, and Munich Medical Chemical Defense 2018. As of today, he will talk about the importance of POCUS in snakebite envenomation. Welcome to the one and only Dr. Ho.
Good morning, everyone. It is an honor for me to have the opportunity to give an online lecture in the Emergency Medicine 2023. My name is Cheng He. I come from Taiwan. I am an emergency physician and working in the Tri-Service General Hospital. I will share our experience in handling snakebite. We have developed 5 clinical steps and established an ultrasound-assisted protocol. I will explain these steps in the following slides. In the clinical steps, the first step is to identify the species of the snake. This can be done by the patient blow the snake body, or patient may be recall or take a picture and video from the snake. If this information is not available, we rely on the detail of the events, such as the environment and the wound presentation, to make a suspect identification. Once the snake species is identified, we select the appropriate antivenom and provide education for the patient. In Taiwan, we have 2 types of bivalent antivenom, one for Taiwan habu and the tree viper bite, we call the FHAV, and the other is treated for Cobra and the crate, we call the FNAB. It is important to inform the patient and the family at this time about the possible clinical disease progression in the next few hours, because the patient may be suffer from the progressive swelling even he had received the correct antivenom. Then during the administration of antivenom, we monitor the patient by a sonography protocol we call the POCUS. And finally, we need to check whether the patient developed any risk factor for the surgery during the management process. Taiwan, there are 6 medical important snake species. These snakes belong to 2 families, Elapidae and Viperida. The Elapidae family contains the Cobra and the Crate. The Viperida family has 2 subfamilies, including the Crotazina and the Viperida. The Taiwan Habu, Tree Viper, and the 100 Pacer belong to the Crotazina subfamily, and the Russell Viper is within the Viperina subfamily. My hospital, located in northern Taiwan, we analyzed total 189 snakebite patients from 2009 to 23. Many of the snakes account for 70% of all bites, with the Taiwan Habu causing the most bites, more than 50%. When we look into the clinical symptoms following a Taiwan Habu bite, we find that the majority of patients experience local symptoms. Less than 10% of patients experience systemic symptoms like the thrombocytopenia or the acute kidney injury. Especially, 96% of bitten patients report tissue swelling and the pain, while 58% complain of the local ecchymosis, and the incidence of the blister and the wound necrosis was 23%. Therefore, Taiwan Habu is the most common snakebite in Taiwan. When bitten, patients do not usually experience systemic symptoms, but the local injury are the major concern in these patients. So let's go on about the snakebite envenoming, and we focus about the local effect. First, we will discuss about the progressive swelling. In this case, this is a 56 years old, and he is a driver. Someday he walked in the garden and he used his hand to sweep the leaf, but unfortunately he was bit by the Taiwan Habu. He called help in my hospital. Immediately we can see the significant pain mark over the right dorsal hand, and the swelling local cyanosis was noted even after 1.5 hours, and the swelling progressed very quickly. And during this time, he had received 6 vials of antivenom, but the swelling still progressed from the dorsal hand to the right shoulder. It only took 7.5 hours. After that, the patient has discharged, and he caused 19 days to recover over his right hand. Who is a 60 years old female. She walked into the balcony at night and she handed the clothes for drying, but there was a Taiwan Habu bit over his right ankle, and we can see the local ecchymosis, local cyanosis, and the swelling. After that, the swelling progresses very quickly. This is post by 3 hours. The swelling progresses to the lower leg and even progress to above the knee. The patient received 10 vials of antivenom, but it cost the patient 24 days to return normal over the lesion site. And we analyzed a total 38 patients who were confirmed to have been bitten by a Taiwan Habu from 2017 to 23 in my hospital. We assess the severity using the Braylock classification, which measures the severity of the swelling, and we can see that only 20% of the patient shows the minimal swelling, while the remaining up to 18% patients ranging from mild to moderate, even the severe swelling. The more severe the swelling, the longer the recovery period is needed for the patient. For these patients, the patient classified as the mild, they usually take an average of 12 days to recover, and the patient classified as the moderate need to take the average of 15 days to return to normal. This is an important observation that should be communicated to the patients and their family at the start of the treatment. This can help alleviate their anxiety about the treatment and the disease progression. As the swelling progresses, the clinician will inevitably have the two questions. The first question is whether my patient has the compartment syndrome due to such swelling. Will it progress to acute compartment syndrome? And the second question is what is the appropriate dosage for the antivenom? Despite the patient receiving the antivenom, the patient is still experiencing swelling. So, is the dose of antivenom sufficient or not? Additionally, acute compartment syndrome is diagnosed clinically. Also, we call it is a clinical diagnosis disease. If patient exhibit these symptoms, including the pain, paresthesia, paralysis, or pallor, even the palsies, the surgery should be considered without waiting to check the intra-compartment pressure value of the compartment syndrome. However, there are indeed many machines available in the market for measuring intra-compartment pressure, like this and this. Even we can use the arterial catheter for management. However, this tool may not always be accessible for clinical emergency department. Furthermore, for the diagnosis of the acute compartment syndrome, the new concept no longer relies solely on a single compartment pressure management. Whether the intra-compartment pressure is high enough to cause compartment syndrome and the subsequent nerve or the vascular damage is related to each patient's diastolic pressure. The difference between the diastolic pressure and the major intra-compartment pressure, we call that the delta pressure. If the delta pressure less than 30 millimeter mercury, and that's the indication of the fasciotomy, because at this time the compartment syndrome may occur. And from the partial and the pathophysiological or the swelling caused by the trauma and the snake bite are very different, because the trauma swelling may be the fracture related and the snake bite is the toxin cause. And as we know, the fracture usually the bone is encapsulated, so the pressure is below the fascia. But the snake bite, the toxin is injected into the subcutaneous or maybe to the muscle layer, but not in the fascia. So the fasciostomy play any role in the snakebite patients? It's a great question. In animal experience, the author has proven that the fasciostomy is not only effective, but may significantly worsen the amount of myonecrosis. So the current research also suggests that the fasciostomy cannot be recommended until further well-designed investigations are complete. After several years of development, my hospital has established a set of ultrasound-assisted monitor procedure. We call it POCUS. It is the point of care ultrasound for local envenomation from the snake bites. It consists 3 parts to assist clinical physician in the scenario of snake bites. Then we will go on these 3 parts. The first step, we use a linear ultrasound probe to align with the swollen area. Under the ultrasound, we can search the cobblestone sign to represent the injury tissue. The cobblestone is here. The tissue, we can see many hypoechoic interstitial fluid surrounding the tissue. This time we can observe its relative position, whether the cobblestone sign is below or above the fascia. In theory, compartment syndrome is more likely to occur if the cobblestone sign located within the fascia. At the same time, the normal tissue can be scanned, and we scan for like this. This is the cobblestone sign located in the subcutaneous, and we use the probe scan along the direction toward the heart and until the normal tissue. This is the normal tissue. Normal tissue is detected, and we find a borderline here. And at this point, we can make a mark on the skin surface and proceed the second part of the POCUS. The second part we call the RPP, the rate of paroxysmal progression. We check the cobblestone sign and the normal tissue, the boundary. We check this boundary and make the mark on the skin surface during the fixed time level, and then we use the distance to divide the time, and we get the rate data. We call this RPP. Like this patient, this is a 66 years old male. He was bitten by a snake while walking in the garden. The green tree viper was suspect. Initially, he has a faint mark on his first phalanx of the right middle finger, and the swelling progressed. So we can use this POCUS second part. We find the RPP, the green line means the RPP, maximum RPP about 11 centimeter per hour, post by 2 to 3 hours, and then the RPP decelerate, so the clinician withhold the antivenom and totally use 8 vials of antivenom. It means the sonography assessment. If this sonography show the RPP decelerate, the administration of antivenom can be stopped. And we go on to the third part of the POCUS. We use this study. This study find that the diastolic retrograde arterial flow is a useful tool to detect and evaluate the compartment syndrome. So we use this method of this study to evaluate the patient bitten by the snake if they have the acute compartment syndrome. When we begin the third step, we need to identify the artery at the lesion site and switch to the Doppler mode. Then we turn the probe to adjust the view to the longitudinal, and use the pulse wave, use the Doppler gate, and use the pulse wave view to display the arterial waveform. The pulse wave view, we can see the arterial waveform. There was systolic wave and the diastolic wave. To monitor and check the waveform during diastolic, if the diastolic waveform become retrograde, it means the intra-compartment pressure is higher than the diastolic pressure. We first conduct the management on normal health male. The health male had a diastolic pressure as 65 millimeter mercury, and we can see the systolic phase and the diastolic phase. The wave was upgrade, and then we elevate the cuff pressure to the 50 millimeter mercury. At this time, the delta pressure was less than 30. It means the acute compartment syndrome may occur, and also we can see the diastolic pressure wave from the upgrade to the retrograde. So we apply this technique in patients bitten by the snake since 2017, and none of these snakebite patients had draft, and so far none of them has experienced acute compartment syndrome. In summary, the composition of the POCUS consists of 3 parts. The first part uses the cobblestone sign to observe the location of the damaged tissue, whether it is on or within the fascia. Swelling within the fascia is more likely to cause acute compartment syndrome. The second part involves sliding toward the heart to monitor the boundary between the cobblestone sign and the normal tissue. Then we mark in on the skin. Measurements are taken at fixed time interval, and the distance is divided by the time to obtain the swelling rate. We call the RPP. If the RPP decreases, the antivenom injection can be stopped. And the third part involving the selection artery in the severe swelling area, and use the Doppler and the pulse wave mode to observe the arterial waveform. If there is a retrograde waveform during the diastole, it is possible that the intra-compartment pressure is elevated. We also perform a video guide summary here. You can use the QR code from here to see the vivid video. We go on the other local injuries, including the breast and the burra formation and the wound necrosis. I also take a case for example. This case is a 62 years old male, and he is a security guard in a building. One day, Taiwan Habu entered the building and he used his hand to sweep it away. We can see that he was getting bitten over his right thumb, and he called our hospital for help. After 2.5 hours post-bite, we can see even to the 4.5 hours, there's still acute bleeding over the vein marker, and after 15 hours, the burra formation, and we can see here is a huge burra, and here is maybe a breast, and the hemorrhagic breast over the fingertip. At this time, the necrosis or the hemorrhagic change is our concern. Also, we suggest maybe the debridement is necessary, but the patient refuses. Patient received total 22 vials of antivenom and following the OPD 2 weeks, we can see the new skin formation below the burra, but the dry necrosis over the fingertip. The patient still refused the surgery, and after another week, by 3 weeks, we can see the dry gangrene over the fingertip. Or we can see that the fasciotomy maybe is not necessary for the snakebite, especially the Taiwan Habu. But in some scenario, the debridement to remove the debris from the wound may still be necessary. Dr. Mao has identified certain risk factors for the Habu bite, such as bite on the finger or the burra and the breast formation, which may require surgery. In summary, when managing snakebite patients, there are several important steps to follow. First, it is crucial to identify the snake species and choose the appropriate antivenom. Additionally, it is important to notify or educate the patient and their families about the potential clinical progression in the coming hours. During the antivenom administration, the pulse method can be used to monitor the location, to determine the antivenom dose using the RPP, and assess whether there is acute compartment syndrome based on the drug presentation. Lastly, but not any less important, clinicians should also assess whether the patient is at risk for the debridement. In the end, I would like to thank my emergency medical team for their support and dedication. I would also like to express my gratitude to these teachers who has been supporting us and providing valuable advice and solution. Okay, this is all the content of my speeches today, hoping to provide everyone with useful information. Thank you again for giving me this opportunity. Okay, this is my speak today, and thank you all.
That was an eye-opening speech. It's essential for us to be well equipped with adjunct such as ultrasound to provide the best treatment for the patient. Thanks, Dr. Ho, for sharing your wisdom with us. Now we will have a 5-minute break. We will meet again at 10:15 a.m. Welcome back, all participants. So, without further ado, it is my pleasure to introduce our third panelist of the day, Dr. Tri Maharani. She's an emergency physician at the Disease Prevention and Control, Ministry of Health, Indonesia. She's also served as the advisor for WHO Snakebite, president of Indonesian Toxinology, and ambassador of Royal Society of Tropical Medicine for Indonesia. She is also actively involved in global scale conferences and academic writing. Please join me in welcoming Dr. Tri Maharani to the screen.
Hello, good morning, everybody. Nice to meet you this morning. And this morning I will present about the Indonesia cases, Daboia Siamensis. In Indonesia, many species of snake. And one species of snake is Daboia siamensis. But Daboia siamensis is neglected cases in Indonesia. The slide is map of Indonesia. And Daboia siamensis, not all Indonesia islands, only in West Indonesia and East Indonesia, Nusa Tenggara. And reportation about these cases a long time ago in East Java or the center of Java, but in the 10 years, I don't have cases in the East Java of center of Java. Now I will presentation about cases in East Nusa Tenggara. Nusa Tenggara have many islands, and the East Nusa Tenggara have over than 100 islands. The special island in East Nusa Tenggara is the Komodo, is the Flores, Lembata, Adonara, and the big island, the name of Flores. The islands is an old island and in the line of Willis area. Because the Willis area, many animal and many plantation don't same West Indonesia or East Indonesia. The distribution of the Daboia siamensis in Indonesia in the Lesser Sunda Island, Longliang, Komodo, Loholavi, Lohliang, Mount Puaki, Rinca is the name of the islands, and the Flores. The Flores have many islands and many area also. Bajava, Danga, Mdabai, Bai, Labuan Bajo, Bomba, Nangaroro, Ndau, Ruing. And the Ende Island, Solor, Adonara, and the Lomlen, Loweleba, Merdeka. Merdeka names is an island also, and the area also. The data from the Smith in 1917. I have data about Daboia siamensis bite in the 2020 until 2023. What the data start in 2020? Because the many years, Daboia siamensis is neglected cases in Indonesia. And I have first data to and helping this patient in 2012. And 2020, I have many data and collecting this data until now and give program in Ministry of Health to buy Antivenom Daboia siamensis. I have 3 data from 3 hospitals in East Nusa Tenggara. TC Healer in Flores Island, Gabriela Hospital in Flores Island also, and hospital in Lembata, Adonara, Komodo, and the little hospital other. And the guideline of the WHO about the category 1 and category 2, the Daboia Siamensis is the category 1. And in Indonesia, the distribution many area, but the cases, the reportase of the cases only are West Nusa Tenggara and East Nusa Tenggara. In the 2020, I have first cases about Daboia Siamensis. The doctor called me about the have patient, the bad condition, and they don't know about the caused species of the snake, and send me about the photo the snake. If I look this photo, I call my friend from the Herpetology Society and identification this snake, and we agree this snake is Daboia siamensis. Because the bad condition is the habitat in Indonesia, Daboia siamensis. The East Nusa Tenggara have many area, and the area in the island don't have many people. It's a open area. And the status location about the bite of the Daboia siamensis, the all cases in the leg and the little cases in the arm and the other location in the body. But in Indonesia, this area have many place from the animal, because the open area. One from the patient, we look the fang mark, and the ICD-10 give me information about Daboia siamensis toxic effect. Sign and symptom, the Daboia siamensis patient in Indonesia have sign and symptom hemoptysis, anuria and hematuria, gum bleeding, general weakness, ptosis, decrease of consciousness, dyspnea, and respiratory failure. And one of the cases, the first cases in the Lembata, we have the bad condition with the respiratory failure, and the doctor gave the ventilator and many bloody from the urine and from the NGD, and not good from the function of the kidney. Intubation and ventilator don't have many in this area. I remember the first cases only one ventilator in the hospital of the Lembata, the little island in remote area of East Nusa Tenggara. And the vehicle flight from Indonesia, from my town, I remember I must go after from the Bangkok by to Antivenom. I must fly from Jakarta Jakarta, Surabaya, Surabaya, go to Kupang, and I think difficult flight go to the area named Lebata. I must wait the flight tomorrow, the day of tomorrow, because not every day have the flight go to the Lebata Island. And the problem about transportation and about the many equipment to helping Daboia Siamensis, I give program in the Ministry of Health to help the many people and many patients in the remote area East Nusa Tenggara about the Daboia Siamensis. We buy Antivenom from the Bangkok for Daboia Siamensis. Is the hospital in Lembata, and you look the very simple hospital, not a good hospital, same the big town in Indonesia, but it's the remote area. And two problem about the Antivenom, because until 2020, in this area is Nusa Tenggara only have one Antivenom named Biosafe from Indonesia manufacturing, a biopharma, but not covered Daboia Siamensis. I must fly to Bangkok to buy Daboia Siamensis Antivenom and give this patient. And every cases until 2022, I must back and go to the Bangkok to buy Antivenom Daboia Siamensis myself. But in 2022, after the program of Ministry of Health okay and settle, the minister gave me a lot of money to buy Antivenom from remote area, East Nusa Tenggara and West Nusa Tenggara, to pay Antivenom Daboia Siamensis. And now Daboia Siamensis Antivenom free from my government to many people in Indonesia, specialists in the East Nusa Tenggara Island and West Nusa Tenggara Island. It's a doctor I'm training to give this Antivenom, and training to many people in this remote island to management of snakebite and give Antivenom from this patient. In the pandemic COVID, I have a special cases about these cases very bad, and I don't have time and the pandemic go to the Bangkok to buy Antivenom. I have one cases I gave the expired Antivenom because I have only expired Antivenom, 6 years Antivenom about Daboia Siamensis. Is the experience very dangerous for me because it's expired 6 years Antivenom, and I must helping with the doctor team of the doctor of the TC Healer Flores Island to help this patient. This patient is the child, 6 years, and the bloody urine with the very bad kidney function, with the edema and very bad result of the laboratory. And we gave 4 vials of the expired Antivenom Daboia Siamensis. And this good result. The end of the story about this patient, the renal function is very good. and normally, and all the sign and symptom is normally also. And many other cases after this condition and after the program of Ministry of Health about the reduction of snakebite, many people in the East Nusa Tenggara and West Nusa Tenggara good condition, and the ministry by many of the Antivenom Daboia Siamensis. We gave many training in the many hospital in this area. My team go to many hospital in the remote area also, and many hospital, there's puskesmas in the name in Indonesia, to give education, to give skill and information about reduction of the Daboia Siamensis cases. And the interest of the Daboia Siamensis because the acute kidney injury and Daboia Siamensis from two proteins, RV-APLR2 and RV metalloproteinase. And we look the problem in Indonesia about not all hospital in the remote area have hemodialysis. And conclusion, the neglected case of Daboia Siamensis in the 2022, we launching of the Indonesia guideline snakebite. One of the pack of guideline, we discussion and gave information about Daboia Siamensis cases. Treatment, diagnosis, sign and symptom, and give many information about it because many people in this area don't know about this species many years. And the government gave many antivenom by from the Thailand production, TSMI production. In the 2022 and 2023, the government buy 200 vial Daboia Siamensis antivenom. And now, I think all cases in the West Nusa Tenggara and East Nusa Tenggara, the many hospital have this antivenom of Daboia Siamensis. And training of the health worker online and offline, because after the pandemic of COVID, very difficult to offline meeting and not many flight go to the many island in the East Nusa Tenggara and West Nusa Tenggara. And we improvisation with the online meeting. Many meeting and many training we arrange in Indonesia Society of Doctor, Indonesia Toxinology Society, and a Ministry of Health arrange this training. We have a WhatsApp group with the hospital, DC Healer, Lembata Hospital, and the other. And I think the reportage of Daboia cases now is a good, different long time ago. And many doctors to contact Ministry of Health about this antivenom, about this deliver patient with the fly or with the sheep. Because in the East Nusa Tenggara, if you have the good equipment about hospital, must go to the province. This province in the East Nusa Tenggara is Kupang. I think the 200 island must go to the big city in the province. But in the 2023, policy of my government to buy many antivenom and many equipment also include the hemodialysis machine, and airway breathing circulation equipment also, ETT and the other, and ventilator also, to have many mini hospital and hospital in this area. I think it's very good policy. The province reports every month to Ministry of Health, and we have the form online. Every day, if have the cases, the province must to send this form online to many people, and Ministry of Health know about it, about the management, diagnosis, and condition of the patient. I know it's not too easy policy because many people in the Indonesia don't know about the species of the Daboia, Siamensis, side effect, and the other. Much day by day to studying and give information and give training and the other many activity every day. Okay, is the special photo from the Lebata Hospital health worker. You look the many local people from the Timor, from the East Nusa Tenggara. And I think the good news from the Indonesia about it, about the program, about the Antivenom and reduction cases fatality, about the Daboia Siamensis cases. Okay, doctor, thank you from time. I'm presentation about Daboia Siamensis neglected cases in Indonesia. Thank you.
Ladies and gentlemen, next, our fourth topic of the day is the management of Cobra Envenomation in a limited antivenom setting by Dr. Simene. He's the head of Toxicology Department of Northern Mindanao Medical Center and a visiting consultant at Capital University Medical Center, Philippines. He has vast experience in handling toxicology cases, including research on methamphetamine toxicity. He has also been awarded numerous recognition both locally and globally. Dr. Simene, the screen is yours.
Good morning, everyone. Thank you for inviting me. I would like to thank the organizers of this event. It is a really successful a 3-week session. So today I'm going to present the management of Cobra Envenomation in a setting of limited anti-venom stock. The objective really is to just share our experience here in the Northern Mindanao, Philippines, wherein there is a limited stock of Cobra anti-venom. So that is the only anti-venom that we have for Cobra only, and none for the Viper. I would like to present a 42-year-old female, a resident from mountainous area of Bukidnon, Philippines. That was brought in our institution. The chief complaint is snake bite at the right foot with a respiratory distress. So the history is 4 hours prior to admission, patient sustained snake bite at the 5th digit of the right foot. There was an intense pain and onset of dizziness and nausea, numbness of the jaw and neck, at the jaw and neck area, weakness of extremities. Thus, this patient was brought by her husband to the hospital. At the time of admission, condition above persisted with diplopia, slurring of speech, and shortness of breath. Patient recall on the appearance of snakes. This is retrieved from the internet because the snake was not caught, and then the patient just presented with this picture, different snakes, a picture of snakes, and the patient identified that it looks like this one. So we concluded that based on the symptoms and with the patient description, we concluded that the involved snake is Nadia samarensis, or Samar Cobra. So at the at the ER, physical exam showed slightly elevated BP, and the respiratory rate is increased, and patient also complained of pain on the right side. There was slurring of speech and unable to fully protrude the tongue, and unable to sustain opening of the eyelids, or there was ptosis. So this was the picture of the patient. Patient was lethargic at the examination, but arousable and follows command. The ptosis was documented, unable to completely protrude the tongue, and then there was hematoma formation at the bite site at the 5th digit of the right foot. The impression at that time was toxic effect of snake bite, Cobra likely at 5th digit of the right foot, accidental with signs of neurologic envenomation. That was moderate. So we gave, because there was a limited stock, we give only 1 ampule. Supposedly, in our guidelines, we will give a starting dose of 5 ampules, but we have only 5 ampules at that time. So we only give 1 ampule for this patient. Since 1 ampule is not enough, we gave neostigmine, 25 microgram IV bolus. Then the symptoms were alleviated for approximately 4 hours after giving the antivenom and the neostigmine. So we gave another dose of IV bolus neostigmine, 25 micrograms slow IV, 25 microgram per kilogram, after the dose of atropine, which was 0.6 milligram IV. But there was recurrence of neurologic symptoms such as orofacial paralysis, blurring of vision, slurring of speech, difficulty of swallowing, and ptosis. So after 4 to 6 hours from administration of neostigmine IV bolus, so we decided, because you cannot give anymore the Cobra antivenom, because patient's respiratory rate improved from 25, it becomes 20 cycles per minute, 18 to 20. So we just give neostigmine drip, 100 microgram per kilogram and 500 ml plain NSS. We give this 4 to 8 hours depending on the symptoms of the patient. If the symptoms increase in severity, then we increase the drip of the neostigmine solution. So patients still complain of minimal ptosis, slurring of speech, and blurring of vision after 8 hours of no neostigmine. So we give neostigmine for around on the time of admission up to 6 days. Then we monitor the patient, and we decided that the patient is okay. So but there is also minimal ptosis and also blurring of vision, but only minimal. So we decided to convert it to pyridostigmine, because our neostigmine stock is also limited. So we converted it into pyridostigmine 1 tab every 12 hours, hoping that the symptoms will not recur. But at 8th hospital day, that there was persistence of minimal ptosis is observed, and slurring of speech and blurring of vision. So we increased the pyridostigmine into every 6 hours. And then we observed that the patient, after 3rd dose of neostigmine Q6 every 6 hours, there was onset of rashes generalized. So we started to hold the neostigmine, pyridostigmine, and give the neostigmine at 25 microgram per kilogram to run for 2 hours. The symptoms have resolved, but at the 10th day, that was the last neostigmine dose that was given at 25 microgram per kilogram as needed. So on the 12th hospital day, no recurrence of myasthenic symptoms. We call this one myasthenic symptoms, as later on I will project some studies or case series. Patient was discharged ambulatory and no weakness. So I just want to show the picture of the adverse drug event due to pyridostigmine. So this happened to the patient. Maybe it is because of the pyridostigmine bromide component. So this is the graph of the administration of neostigmine and recurrence of symptoms. So it shows here that the total dose of neostigmine is around 60,000 microgram or 60 milligram, and the atropine is around 16 milligram in 10 days. So we've searched in the internet, and yeah, it was some of the articles said that the symptoms, the recurrence of myasthenic symptoms will really last up to 10 days. But then when we search for case reports, I think this is the first case that the myasthenic symptoms is prolonged. Maybe because we have not administered enough antivenom. This was the lab results of the patient. There was reactive leukocytosis, and some of the result which showed only minimal hypokalemia. So at the hospital, these were the given meds in the hospital, and home medication, we continued the antibiotic per orem, and then the steroid for 5 days. So after 4 weeks, this was the appearance of the wound of the patient. So we know that we know a lot of data about snake bite. So here in WHO and in our locality, the Research Institute of Tropical Medicine, 2011, we have this data that 50% of patients were aged 18 to 28-year-old. So mostly are males. And in WHO, the updated data is on 2019. This is the tabulated data that we've got. Though when I will show this one in a graph, it showed really that male, most of the victims composed of males rather than females. Comparing the neurologic signs of envenomation and with no neurologic signs of envenomation. So maybe we can conclude that 1 out of 30 have this neurologic signs of envenoming. So in the Philippines, we have this kind of NAHA. So we have also the king cobra here. So our patient, the involved snake is the Naja Siamensis. So I will just discuss the elapid venoms, which is the cobra belongs. So it is a polypeptide neurotoxin that is mostly in that venom of the cobra. So this caused respiratory paralysis by blocking the nicotinic acetylcholine receptors at the postsynaptic motor endplates as it showed in the picture. So mostly alpha bungarotoxin or alpha cobra toxin will bind to the postsynaptic cleft. So neurotoxicity include all the signs that was being experienced by our patient. So we have here a study in 1998 by Ganata that they have 65 patients and all showing this kind of symptoms. So with the test of hydrophonium test, it is surprising that when they test the acetylcholinesterase antagonist test, comparing the myasthenia gravis and the snake envenomation, their test is negative. So maybe that were the cases of alpha neurotoxin, because most of the nicotinic receptor or receptors in the presynaptic cleft that is involved in inhibition by venom will not respond to the neostigmine administration. So they said that this is a myasthenic syndrome in 1998. So this is really the symptoms that were being mentioned in that case series, in that study, were really present in our patient. And the most concerning outcomes is bulbar and respiratory paralysis. I find different journals in the online, the internet, and finding the new stigmine that is incorporated in the protocol or guidelines in the Cobra Envenomation or ELAPID Envenomation. But then in the Asclepius Snakebite Foundation, I find this algorithm, and yeah, they really use the neostigmine, and it is used mostly in the patient having progressive neurotoxicity or neurotoxicity that is persistent. And also we have different dose of neostigmine and also atropine. So I will show the role of neostigmine and elevating neuromuscular symptoms. So it is a cholinesterase inhibitor and used in the treatment of myasthenia gravis. It does not cross the blood-brain barrier. So by inhibiting acetylcholinesterase, more acetylcholine is available in the synapse. So therefore, more of it can bind to the fewer receptors present in our patient because of the nicotinic receptor inhibited. Some of the receptors will be now exposed to more concentration of acetylcholine. So in our guideline, we recommend this if Cobra Antivenom is not available. So we just follow this one. Neostigmine, 100 microgram per kilogram IV infusion over 4 hours. Or you have a bolus, slow IV, 25 microgram per kilogram. In Olson's Poisoning and Drugs Overdose textbook, they have this also a dose of neostigmine, how to give neostigmine. So usual adult dose is 0.6 to 1.2 milligram or 1,200 microgram maximum bolus dose, and the children will receive 0.01 or 0.04 milligram per kilogram. In the Principles of Internal Medicine in Harrison's, they have this dose also for neostigmine. So for those snake bites that will manifest a neurologic envenoming. So different studies were reviewed, and it was shown that on 2006 there was a retrospective review on the data of 11 individuals. So the 2 of that patients received neostigmine, and it has really a good outcome. And when I dig in further, the two patients were really a case in Brazil on 1996. So a 20-year-old male and 38-year-old male. So notice that they give, in the first patient, 20-year-old male, they give 0.5 milligram of IV atropine. Then after that one, immediately they give neostigmine 1 milligram. Times 2 doses, then the patient was discharged after 2 days. But here, in this case, they give also antivenom. So the second patient, 38-year-old male, also the patient was given also neostigmine times 2 doses. But then since there is a persistence of neurologic envenoming, so they decided also to give infusion of neostigmine at 4 milligram in 250 ml glucosidic solution, 50 micrograms per minute. So they also give atropine at 4 milligram in 250 ml glucosidic solution at 30 micrograms per minute. So this patient was discharged after 3 days. For the another journal from Said Ali Raza, 2016, there was a 31-year-old male And then this patient was intubated because of black mamba bite. But this patient was also given antivenom for 4 doses. So they have a lot of antivenom. But then the weakness persists. So they decided to give neostigmine, 2.5 milligram or 2,500 microgram plus an injection of atropine 1 milligram. And then after that one, patient's condition improved. So really, the neostigmine will really help even if there is a antivenom that is administered. And the last patient, 2021, a 60-year-old male. So given 10 vials of anti-snake venom, but then they also give neostigmine plus atropine. So a total of 4 doses, and the patient survived. So it really shows that neostigmine will help. So that's why in our case today, so we concluded that this is the first case in our institution, and I have not seen any case that lasted for 10 days of myasthenic syndrome or symptoms, and also a 60 milligram of neostigmine, total of 60 milligram was given. So in the case presented, there is a neurologic signs of envenoming. So transferring to higher institution because we come to realize that neostigmine is really important just to suspend intubation. If your patient showed weakness and increasing respiratory rate, then maybe the neostigmine, which is readily available and available in all drugstores, can help. So in those areas infested by a lot of cobras, so neostigmine will really help. And close monitoring of recurrence of patients' neurologic symptoms is advised, and also educating the patients on the symptoms and also the mechanism of neostigmine, because the patient is keep on telling maybe antivenom is needed, but then we tried to really procure antivenom. That's why we explained really to the patient that because they search in the internet, because internet now is accessible, and most of our patient really rely on googling the internet for their disease treatment. So that's why they kept on insisting that they really need antivenom, but unfortunately our antivenom stock is limited. That's why we explain to the patient that these symptoms will disappear, because it showed in the studies that a patient will disappear after 2 days to 10 days. And we keep on saying that neostigmine will really help, and the respiratory depression will not really recur. No, or if the respiratory depression will recur, then maybe that's the time that we will give another dose of antivenom. So I think that's the last slide. Thank you. These are my references.
So a big thank you to Dr. Simene for the insightful talk. Thank you for updating us with the latest advances and findings. Dear all, without further delay, we will proceed to the forum session, inviting all speakers, including Prof. Khaldun, to turn on the cameras. And as for the participant, you can key in the question in the Q&A box on the Zoom platform. Okay. Welcome to every speakers and Prof. Aldon as well. So we'll begin our forum session. For the participant, you can ask the question in the Q&A box. So I have the first question. I think this question is related to Dr. Hassan regarding the first presentation. So the question is, how do you monitor the effectiveness of antivenom in intubated patient, and on what parameters the boy was decided for extubation 6 hours later? Dr. Hassan?
Your mic is off, Hassan.
Dr. Hassan? Kindly unmute.
Can you hear me now?
Yes.
Oh yeah, sorry. Okay, thank you so much. As I have said, this is quite a genuine and a very practical question. And for sure, we need to answer this kind of questions. But before that, I just want to say a few general concepts whenever you are dealing with these kind of scenarios. Of course, not every patient with the neurotoxic envenomation need to be intubated. And I think we have seen few examples of presented case. That's we start with. Number two, when it comes to envenomation in general and neurotoxic envenomation per se, it's an spectrum. What I mean by that, it could be just a bit of numbness somewhere in one side, and to the far end, it could be a very severe debilitating overall neurological collapse. I mean that the patient simply might just be paralyzed. So that's the idea of the spectrum. So let's go back to our case. For that little boy, he was bitten by Malayan crate. And as I have mentioned, some specific about the Malayan crate, that it has very small, very kind of short fangs. So
it's a banded crate, not Malayan crate, I think.
Sorry?
It's a banded crate, not Malayan crate.
Oh yeah, so
Yeah.
I assume that Malayan crate is part of the banded crates. Probably Dr. Khaldun, Prof. Khaldun will talk about that probably later on. So now, the specifics of that crate was short fangs and very thin fangs. So the inoculation of the venom itself is like kind of a hypodermic. So being the venom injected in a hypodermic area, that means the spread, it might be very slow. This is from the crate point of view. From the response point of view, the response to a venom, again, there is a spectrum. Some patients, they might respond differently to the envenomation. For that boy, obviously, his main symptoms belong to upper respiratory, mainly swallowing probably, and for the ptosis. And as I have said, still that boy, to the point we have intubated him, still he can obey commands and he can lift all the four limbs. So why we get that boy intubated to start with? Simply, we need to protect the airway first because he started drowning. And second, we just want to support the airway until that effects of venom gone away. Luckily, we have started the antivenoms and that patient get intubated. So of course, it's very clear if someone intubated, you obtended everything and there is no way to assess anything. So the idea here is, once that boy was intubated, he was kept in a very light sedation. No paralytic 8. So he was in a constant assessment. How we assessment? We keep the sedation light as possible, and we'll see how he will going to respond. So by 5 hours of incubation, they kind of wean off the sedation, and they will look for how he was going to respond in terms of obeying command, and in terms of if he is able to initiate spontaneous breathing. That's by just probably putting the ventilator into SIMV mode, probably, because the patient can negotiate with the machine. And also we look into the pupils, how the reactivity is. So based on these kind of parameters, we can always assess our patient who might have neurotoxin envenomation. Because of these parameters, they found that, I mean, our pediatric ICU, this boy is like doing fairly well. And he's responded fairly well to whatever measure that we have done. And by 6 hours, basically he can just be ventilating by his own with a very minimal ventilatory support. And by that time, they have decided just to extubate him, and we'll see how it goes. And interestingly, just next day, he was stable enough to go to the general ward, and by day 3 of intubation, he was sent back home. So to summarize the answer for this question, the response to the venom varies between patients, and envenomation itself is on a spectrum. And yes, if someone gets intubated, still we have some objective measures we can do it during, after intubation to assess how the patient might react. And based on that, we will decide whether or not to continue intubation. So that is how they have done. But for sure, Prof. Khalil will come back to us probably about that, the distinction between the Malayan crate and the banded crate.
For a simple reason, the geolocation is not in Brunei. Basically, main crate is not in Borneo. So what you have is the banded crate. So that's rather clear cut. So easy for you. You don't have to do many crates. You just deal with the banded crate and also the red-headed crate. Okay, so that's one. Secondly, it's interesting that this child was intubated, ventilated, and to me, it looks like it's a prophylactic approach. It's not really a sign of real need for the airway intervention at that point in time. I assume if you look at the timeline, I think you gave the 3 vials of neuropolyvalent quite early as well, isn't it?
Yes, and I
How
think
many
I totally agree with you. The intubation was, we kept very low threshold to intubate this child.
Yeah. How many hours since the incident that you gave the antivenom or the symptom?
The issue is we don't know exactly when was the bite, but the symptoms was started around 12-ish. And you know, Brunei is like you can just drive 5 minutes and you'll be in the hospital. So almost like within, if the bite was around that noon time, it could be just within less than an hour or so.
Yeah, so that's another point. Early appropriate antivenom for crate bite is also can play a role. The longer you wait, the more damage to the neuromuscular junction happen, and therefore you can't reverse with no matter how many amount of antivenom you give. You can actually consider giving the neostigmine, as mentioned by Rutchell, that you can, I mean, some say there's no point giving neostigmine for crate bite, but you have to understand that crate venom has both alpha and beta bungarotoxins. So similar to the
Cobra.
Cobra bite. Yeah, you can actually reverse that part of the toxin. You will see partial reversal, and that could help tilt the decision whether to intubate or not intubate the patient. So we've seen a few that we gave new stigmine to patient after given the first dose of antivenom for crate, and they still responded much better after given new stigmine. It will not like fully reverse, take a few more days, but we keep on giving the new stigmine and the patient revive well. Okay, so especially the ptosis. All right. So the other thing that that we have to consider here is actually the identification. So I assume they kill the snake. Did they kill the snake? The family.
Yes.
Yeah. So
That the things.
yeah, they brought the snake, the dead snake to you, or did they take a picture and send to you?
No. So
For
what was
consider.
happened was, as I have said, this boy was brought in by the father, and the rest of the family they just stayed back home. And later on, just around that incubation time, some of the family members came and they said, "Hey, we have found a snake just in front of the house, in the kind of wood planks." And here we have like in Brunei.
Yeah. Go on.
Yeah, so here in Brunei, we have a habit that whenever you find something outside, you just call the boomba. So the boomba came, what they have done is they just extract that snake and then just throw it to the bushes, because this is like the far end around the Sungai area. So because we don't have, so we keep showing them pictures.
No, I mean, did they take a picture of the snake?
Themselves, no.
Oh, okay, so this is also very important point. That is, many are actually too early jumping to conclusion. So sometimes wherever snake we find, but there was no real connection between that snake and the patient, we assume that was the snake. So always caution when you write down the diagnosis. Never really first of all mention the species of the snake if there is no direct visualization or contact with the snake. So very important. So you treat still a syndromic approach with possible, in the bracket, possible Bungarus species. In the case of Brunei, probably just Bungarus fasciatus. Okay, so never put as straight away diagnosis is Bungarus fasciatus bite, because we did not have a test to confirm that was the envenomation from Bungarus fasciatus, right? We don't have like the venom detection kit like the one in Australia, for example. We don't have that, so it's always through observation of the sign and symptoms. Okay, so yeah, I think we have a lot of very interesting questions. Maybe Amirul would like to put forward the questions.
Okay. I will address this question to Dr. Tri Maharani. In your locality or area, if there is no available antivenom, do you consider using hemoperfusion for your snakebite patient? Dr. Tri Maharani?
Okay, thank you. I think to help many patients with the hemoperfusion, I think to have with the emergency helping, airway, breathing, circulation, disability, and the other. Give to good helping with good equipment. I think the many people in Indonesia, health worker, know about the ABC, and many mini hospital also. If the hemoperfusion, I think we have the knowledge about to helping with the many equipment and mini hospital. Infusion from the liquid, infuse, and the other. But the 10 years in many cases with the snake make the hemoperfusion, the first one, the helping ABC, I must to helping with I go to the other country. Dr. Carl, no, I buy the myself many antivenom to Bangkok. And now my government pay all to antivenom. I think now the many remote area not have the problem about the case snakebite, because the all province have the 5 antivenom, and the Papua have 2 antivenom from Australia. I have sea snake also, and many antivenom polyneuro and polyhemato also, if the doctor don't know the species of the snake, the snake bite. I think now in Indonesia the big problem have the little solution about the helping. Dr. Carl, you help me also to answer this question. You know many situations in Indonesia, Doc.
Yeah. Congratulations anyway for the antivenom for the Daboia Siamensis. So it's very important to understand that the hemoperfusion or dialysis, as you call it, is not to neutralize the venom. You understand? So somebody with kidney failure or kidney injury, acute kidney injury, and a hemoperfusion could actually done, then you do that to correct that problem. Similarly, it will not actually neutralize the venom, so the venom is still in circulation. So you return back. So they still require antivenom. So similar with the new stigmine, as Rutchell mentioned, it doesn't actually neutralize the venom. As you understand the pathophysiology and the chemistry of the new stigmine or anticholinesterase is actually a competitive binding, right? So it dislodges that neuromuscular junction, but the venom is still there. So that's what, Rutchell, you saw your graph. You see a periodic paralysis going on, and after every new stigmine is because of the half-life of the new stigmine. So it's a very short, rather, well, not overly short, but rather short new stigmine effect. And when it reaches the half-life, the venom goes back into that binding site and causes paralysis. So it's a periodic thing. So if you don't have the antivenom, you will actually face this problem. That's what you mentioned correctly, that because the patient did not receive adequate amount of antivenom in the first place to mop up the venom that has been displaced at the neuromuscular junction from providing new stigmine. Okay, so this is a temporary measure, but it's not, I would say, the ultimate measure, and therefore some people probably say, oh, new stigmine works, therefore we just give new stigmine, which is not true. So you have to understand that the venom has to be neutralized first with the antivenom, and new stigmine is just to give that age or give time or buy time until such a time that the patient can actually breathe on his own, and all the venom has been broken down by the plasma enzyme. So that is very important to note, because some people recently I encountered that we don't have to give antivenom now, we have a new stigmine, which is not true. It's a wrong way of looking at solving the problem. So again, efforts should be in the primary is to provide the appropriate antivenom in terms of stocking and so on. I think you have to address that issue, and then in the situation where new stigmine can help, buy time and so on, or improve the response or testing, for example, then you can use it. And this is only for the neurotoxicity, right? There's no point giving this to pit viper envenomation. Okay, so that's one thing for certain. Okay, good question. Any other response from anybody else who would like to say something about this issue? Any other speakers?
I think probably this is another question to Prof. Calder. For the use of newstigmines, let's say in a crate. Yes, as we have mentioned, a crate is predominantly pre-synaptic kind of beta vangarotoxin. So that is not much to do with the post-synaptic end plate. So in this kind of scenario, if we are like desperate, let's say we are desperate, can we use newstigmine as kind of measures to mitigate the things in the absence of course, antivenoms and all this. We do know that antivenoms is not available everywhere.
Yeah, so I've already mentioned earlier that you can actually give to actually see is there any further improvement to the neuromuscular response, right? Motor response. So from our experience, we have done this, and we've seen that obviously the antivenom is optimal. You have to optimize the antivenom first, but there is still some residual, as like your case, like Rutchell's case, some residual ptosis left and so on. And when we give this new Simene, it improved. So not fully, but improve significantly. The patient feels the difference. So we do give like this periodic new Simene to patient who has been receiving, who had received the optimal amount of antivenom in the first place. Okay, so if the antivenom is not optimized, you still need to get the number up, basically the volume of the antivenom up. Okay, so new Simene is just to buy time in a way. But if it is a bungarotoxin beta, then obviously once the destruction already done, no amount of new Simene, no amount of antivenom will actually reverse that. It will take time. Okay, so we had one case recently last month in Johor. It takes him about almost 1 month in the hospital. Okay, but we did see in him when we give the reason being the antivenom was slightly late, so he arrived late, so it was a bit delayed and partial recovery with the antivenom, and then we give the new Simene, we see added like maybe another 25% improvement from the total from the response. But we still, he did not sustain it over time and take a slow recovery. Took him about almost 1 month in the hospital before discharge. So that's a natural sort of recovery from the injury to the neuromuscular junction. Okay, so bear that in mind. New Simene is not antivenom. Or hemoperfusion is not the way for neutralizing venom. So you deal with the patient, physiologically, and then you support whatever you can. So that is the way that you have to be clear in that sense. Okay. Some other good questions. Anybody else?
Okay. The next question I would like to address Dr. Ho. What is the procedure if the snake could not get identified and the polyvalent antivenom does not have effect? Dr. Ho?
Yeah, I think maybe this time you need to go back to see first, maybe the patient did not suffer from the snake bite. And the second, if you can truly identify the snake species, as the doctor call, maybe at this time you need to give the patient more time. You need to add more antivenom and prepare even to assess maybe the patient develops some risk factor of the surgery in the next hours. So in Taiwan, our antivenom usually has good quality. So we only have the bivalent. We did not have the polyvalent antivenom. So and our snake compared with other country, we are usually easily to identify. And so in my country, this condition is not usually happen. Yes. Okay.
Yeah, so that's a very important point. You always have to, that's why we always stress, as Dr. Hassan mentioned, very important that we do a close serial observation of the patient, pre-antivenom and also post-antivenom. So Dr. Ho mentioned how close serial monitoring, the RPP, the pain score, the progression of the swelling can actually help you make the decision whether the patient receive adequate treatment with the antivenom, or in situation where you do not see any effect within the first 1 or 2 hours, you actually need to consider topping up the antivenom to the maximum that you can actually have for the antivenom. So in the past, I still remember, Dr. Ho, when before we do this, before we embark on this ultrasound, the patient receives so many antivenom. Whereas,
Yeah,
you know, for as long as there is swelling, they will give antivenom. But I said, why? It will not, swelling will not come down immediately. But what you see is the progression of the edema proximally, right? The speed of progression. So it's already decelerating and actually it's already stagnant, but they still give antivenom because there is swelling there. So that is also a wrong concept. And until we came about with this POCUS protocol, we see that the number of wastage of unnecessary giving of antivenom when the symptoms is already responding, we save a lot of antivenom, actually, a lot of resources. And the patient is actually, of course, reduce the risk of developing hypersensitivity reaction from the antivenom anyway. Yeah. So those are the best, most important thing, as Dr. Hassan said. You have to be very vigilant in terms of observing the sign and symptoms of patient, okay, documenting it, and measuring things, okay? So measure not distance, but speed of progression. So a lot of people document inappropriately. So that's why we have to do a lot of this training, how to do the RPP and so on. Okay, so next question. I think there are many good questions there, I see.
Okay. So the next question I will address to Dr. Simene. Is it advisable to suck the snake bite? If not, what is the best approach, especially if the incident happened in wilderness? Dr. Simene?
Yeah. It's a good question, and it is practiced in the mountainous areas. No, it's really a common practice in the mountainous areas where people have no access to hospital or to any medical facility. But it's a big no-no, right? Because in a given instance, if you will suck the bite side, and if there is really a venom, so there will be now two patients, now the bitten person and the one who sucked the wound. Okay, but that is not effective because the fang of the snake, inject the venom. So what will really do is to try to delay the travel of the venom if ever there is really an injected amount of venom. So how to delay the transport of venom is to have delaying compression bandage, especially for Cobra. But for the vipers or those venoms that can cause blood coagulopathies, maybe we will transport the patient immediately to hospital because what will kill the patient is really the neurotoxin of neurotoxic venom because of respiratory paralysis. That's why we advised for delaying compression bandage around 50 to 70 millimeter mercury or 70 millimeter mercury. The elastic bandage, so the advised by WHO, most especially to cases of um, cobra snake bites. So no for sucking of the wound. Thank you for that question.
Okay, so just to add on, Dr. Rutchell, the PPI, just be careful that it's true, you give to the highly neurotoxic snake with that causes minimal tissue injury. So some cobras can cause, as you see your case that you show, the suspected, I wouldn't say directly it is, I would say suspected or Naja Siamensis, that tissue destruction. So if you apply PPI, you can actually make the local tissue necrosis worse. So just be careful in that. Choose the species that you want to do the PPI properly. Otherwise, immobilization is sufficient. Okay, you don't have to proceed with the PPI. Okay, so right. Next question, Amirul. Oh, Amirul is gone. So in the wilderness, I think obviously don't suck, but you need to call for help. So never go to wilderness on your own, basically, and make sure you have enough battery and able to communicate with your mobile phone for help. So in Malaysia, for example, we have experience sending helicopter to someone in the jungle who got bitten by snake, and they are airlifted, winch up to helicopter and sent to hospital. So we have experience there. Okay, so it's possible. Right.
Okay, thank you, Doctor. So I think the next question, I think the best is Dr. Maharani to address. Was there any side effect to your patient while using the expired antivenom?
Okay. I have to share this data. It's okay, Doc? Yeah, a little time. Okay. The patient with the expired 6 years antivenom is not a bad side effect, and the platelet and creatinine it's okay and good result to the patient until not sequel from the expired this antivenom. The urine after antivenom it's okay also the production from urine, and the condition you look the edema and other sign and symptom is the normally also. I think because I gave this expired antivenom in the emergency situation, it's the pandemic, and I'm not to give fast, but I give very slowly because a child, and I'm to observe. I'm in Jakarta and observe this patient in TC Healer Flores. It's Nusa Tenggara. Time by time, after the 3 hours, I'm called the doctor and the nurse and give the discussion and the other. I think if not to the emergency situation, I don't give the expired antivenom. And I think I have many experience with information with Dr. Carl, yeah, Doc. You in the pandemic situation give many country expired antivenom, and I think it's a good solution also because the pandemic situation many people don't not go to the other country. I don't buy to Bangkok and fly to go to Bangkok to buy Daboia Siamensis antivenom, and the solution I think the expired antivenom, but start of the give this antivenom, you look this dilution of the antivenom. If not clear, I think not good this antivenom. If the clear and uh the good from the solution, not the color chocolate or the red and the clear this color. I think it's good to this patient as I have experience about the 6 years antivenom Daboia Siamensis not sequel.
Yeah, so that's a very interesting question actually. Yes, we have experience of using expired antivenom. Okay, so it's even more than 6 years. I give you an example. In Japan, there's one snake called the Rhabdophis tigrinus or Yamakagashi, and they produced antivenom. The last production of the antivenom for this particular species was back in more than 20 years ago, and they still keep antivenom. They still keep the antivenom in stock, and they keep on testing it every year. And seems to be working well, even after more than 20 years. So, so they did not produce it anymore because there were very little number of people who got bitten by Yamagagashi, but there were cases of death before. So therefore, they still keep, and they keep the expired antivenom to be given if there is a case. Okay, so we take that as a good example. One. Second is that you have to look, as Dr. Mahak rightly says, so if it is clouded and the color change when you reconstitute, then you should not be using it. And of course, there are ways to keep the antivenom. So keep the antivenom, the expired antivenom, as per the non-expired antivenom, and that will prolong the life span of the shelf life of the antivenom. Okay, So we have used this recently. In the past few years, we have published this data, the response in Laos. So you can read up that paper. Maybe we can share the paper in the chat later. Okay, so you can see that we did a preclinical testing of the antivenom to see the efficacy of the antivenom. We see no difference between those who are expired and those which are not expired. So both has the risk of course, causing a reaction, but that doesn't mean that the one expired causes more hypersensitivity reaction. Okay, so that's not what we experience. We find it almost the same. Okay. All right. So leave your option open, and please. But doesn't mean that because you can use expired antivenom, you're not going to buy new antivenom. It's not correct either. So similarly with the hemoperfusion, similarly with the new stimulants, that is not what do you call the way to go? You only use expired antivenom. That's not correct. In Malaysian situation, for example, we still keep the antivenom, the expired one, in our pharmacy for at least another 3 to 6 months on standby, just in case that we have a case where we do not have enough antivenom. But at the same time, we will actually buy or order new antivenom from QSMI. So while waiting for that antivenom to arrive, we can actually have our so-called emergency stock of the expired antivenom until that the antivenom arrive. Okay, so don't get the message wrong. There's a role for expired antivenom, yes, but you have to understand what's the indication to use it as well. Okay, and as Maha said, if you have non-expired, use the non-expired first. Okay.
Okay, thank you, Doctor and Prof.
Sorry, can I just have a comment here? I think this is quite a fascinating discussion to me when I hear this expired antivenom. Yes, we totally agree that whatever we do for the best of our patient, but at the same time, we shouldn't forget that we are like in an era, everyone is like kind of very medical, legally oriented. And I don't know, what are the legal boundaries for this kind of practice? I'm not talking about the medical point of view, but from the legal point of view. I'm sure probably Prof. Khaldun or Dr. Maha or our other colleagues, they might have something.
Yeah,
on this.
so that's a valid question. That's a valid question. So we actually always ask the patient with disclosure and also informed consent. Okay, so whatever I already mentioned to you just now regarding expired antivenom will need to be conveyed to patient, and the patient need to make the choice. So in the case of Laos that we did with Dr. York Blessman and his team, the consent was always taken before option of giving. So they have the option of to get the expired antivenom or nothing at all, because at the time there was no other antivenom. So to get the antivenom, or they go to Thailand themselves, to the border town hospital, and get the treatment there. So some of them did that. So they decided not to take the expired antivenom, and they go by themselves to the border town and to get treatment with the Thai antivenom over there, non-expired. But mind you, those who accept, for various reasons, because as you know, many of them are not well off, so they accept out of pressure in life. And they recovered. I mean, they did well. They survived, and there's no risk of course, more than the non-expired antivenom. So in that situation, we already have that disclosure that you have to ask for every patient. Whether it's antivenom is expired or not, you still need to get the consent of a patient. Okay, so this is a control drug. Yeah. Okay, but especially so with the expired, you have to explain that. Okay, and we have the articles and so on. You can give it as a supportive reference for patient. All right.
Yeah,
Okay.
and my patient also same. I gave the infant consent to the family of the patient and give information about the doctor to DPGP, yeah, the name in Indonesia, about the anti-expired antivenom side effect and the other. But it's okay, but not now. My government buy many antivenom, and I think the expired antivenom only in the emergency situation also, not the everyday, but the emergency situation.
Okay, doctors. So the next question, I address to Dr. Ho. So
Yeah.
what is the first aid to be given if bitten by a snake?
In Taiwan, I will tell him to go to hospital immediately. There was no enough evidence support for any kind of pre-hospital in Taiwan, including the bandage, including the sock, or even the cutting. In Taiwan, we educate our people or patients. If you bitten by the snake, you can take the picture, or even you can call the snake to the hospital, and we identify the snake and provide the antivenom. The antivenom is the first choice and is the only way treatment for these patients. So maybe we are lucky because our Taiwan is a very small island. The patient call the hospital relatively easily. So maybe I cannot provide any good or well advice for the pre-hospital management for the snake bite. Okay.
Okay, thank you, Dr. Ho. Next question, I would like to address Dr. Hassan. Do we routinely give avihydrocod, piriton, and atropine to all neurotoxic snakebite envenomation? Someone saw that in the treatment plan, and I saw that child heart rate was 170. Is it dangerous? Kindly offer your opinion, Dr. Hassan.
All right, thank you for that question. Basically, as I have said, that patient child, when he came to us, basically, we don't know whether he was bitten by the snake to start with. So initially, what we have seen is just someone who's like lethargic, progressively getting kind of declining on his DCS, and then he keeps on rolling. So to be honest with you, initially we thought more about probably ingestion of intoxicated substances. And at the back of our mind, we kind of thinking it could be some substances with organophosphate. So we said, okay, this little boy, he looks drowsy. He started drooling saliva. So we said, okay, let's go syndromic. And we assume at this point of time, it could be something to do with like kind of anticholinergic things. So based on that, we start the atropine. And while we are looking for the way out, we thought, okay, this is also, it could be some sort of reaction, all right, to whatever he has assumed he has ingested. So basically, hydrocod and the piriton, hydrocod and piriton, yes, was given just based on assumption. And the atropine was given just to control the pooling of or drooling of the saliva. But once we get the things right and we come to know that this patient has bite, for sure, if we do know that he was bitten by a snake from the get-go, I don't think that there is any reason to give hydrocod because there is no any clear allergic reaction. I'm sure we're not going to just give atropine because clearly that pooling wasn't because of hypersalivation, but because simply he cannot swallow well. So in that kind of case, the atropine might not help much. So based on this, when it comes to snake bite and specifically about envenomation, your first big gun will be the antivenom if you have it. Give it. Of course, sometimes snake bite might not just an envenomation. Probably it might be accompanied by some allergic reaction. Of course, if you have a clear evidence of associated allergic reaction, yes, you can give pyritone, yes, you can give hydrocortisone. And in a certain setting, as Dr. Simene case, that also allergic, that's also neurotoxic inflammation. And in this scenario, for sure, atropine has a role along with the newstigmine. All right, so that is my take on this. Thank you.
Thank you, Doctor. So the next question I would like to address Prof. Khaldun. Should antivenom not immediately available at a facility but otherwise neostigmine? Would neostigmine bolus administration be beneficial at primary contact while transferring to facility with antivenom take place? Prof. Khaldun?
Okay. So that is actually me.
Your line's a bit
Yeah, it's line is a bit
interrupted.
bad. But can you hear me now?
A bit interrupted.
Yeah, okay.
Prof,
Can
can
you
you?
speak? Hello, can you hear me?
Can.
Okay. All right. So that question, whether to give neostigmine while transferring the patient, is why you want to give neostigmine if you're already transferring the patient. So is the patient already intubated or not? So you don't give even antivenom or even any other drug, you don't give prophylactically, or just you want to sleep over on call, you give patient antivenom. That's not the right way of giving antivenom. You have to have a clear indication why you want to give certain drugs. As Dr. Hassan mentioned just now regarding hydrocot and also atropine, right? So there was actually misunderstanding of the physical presentation of hypersalivation. That is actually why they give the atropine, but patient actually unable to swallow because of muscle paralysis. Okay, so that was not the reason why you give that atropine. So anyway, for neostigmine, if the patient is already intubated, why do you need to give neostigmine to the patient? I don't understand why you want to so-called reverse while on the way. So there's no reason why you should be giving. So I think that answered this question. If let's say the patient is not intubated, question is still again, why do you want to give neostigmine if there is no indication to give antivenom? So yeah, I don't see the reason for that. Okay.
Thank you, Prof. So next question is for Dr. Simene. Is the application of Nikkei useful? If yes, how we monitor the circulation assessment? Dr. Simene?
Yes. Thank you for this question. When we say tourniquet, it is in when we hear that one, it's like we're extracting blood, okay? But in snake bite, application of tourniquet is not advised because I understand that the ultimate goal is to really stop the travel of or the spread of venom from the injection from the bite side. But we must remember that we also have this circulation to maintain in order for the tissue to be alive. Okay, so um, the tourniquet is not advised, and then if the snake is really identified to have a neurotoxic venom, then as I've said, you can immobilize and apply a delaying compression bandage. So you can search it. It's not a tourniquet, it's just an elastic bandage that can slowly slow the flow of the lymphatics and not the arteries or the venous circulation. So be sure that the snake has a neurotoxic venom. So that is only delaying compression bandage because you are transporting the patient to a hospital which has an anti-venom or the capacity to intubate or the capacity to have the ICU and also all the critical care. So thank you for that question.
Thank you, Dr. Simene. Next question, we'd like to ask Dr. Maharani. Is it possible for the patient to develop immunity to certain snake bite after an incident? Dr. Maharani, you are mute.
Yeah. Okay. Pardon this question.
What is it any possibility for a patient to develop an immunity to a certain snake bite? Is it possible?
Okay. I think because the snake bite is the humoral immunity, I think different with the many infection from the virus of the bacteria, and because the envenomation is the special cases in the body. If the we have the phenom in the phenom to envenomation in the body, I think the solution about it is only the binding the phenom with the antivenom, and not to the other condition and other treatment. In Indonesia, now the very famous about the envenomation with many traditional method. The famous now is the with the hot water. I think the snake bite gave the wound snake bite with the combustion, and I think many condition don't know the many people about the immunity of the envenomation.
Okay, thank you.
Yeah.
Any additional points from other speaker?
I would like to share we have this in a show, a TV show entitled Kapuso, Jessica Soho. So I think the Venom Man, that is the name that you type in the URL in the YouTube, Venom Man Philippines, wherein the blood was tested because this man is slowly injecting certain amount of venom, Cobra venom in his subcutaneously. So the RITM tested his blood, and it really has antibodies. So maybe at some of the because the venom of the snake contains a lot of components. So maybe some of the antibody will develop from that TV episode. And also Bill has when you search the name of Bill Haas, he was also injecting small amount of venom, and yeah, it was proven that there is antibody in the blood. But I think some of the antibody only.
Okay, thank you, Dr. Simene. I have one question. Is it possible if an individual consume snake venom, is it can cause just purely DI symptom or can cause systemic envenomation? I'm just curious. Anyone?
Your mic is mute, Hassan.
Dr. Hassan?
Oh yeah, sorry. I said I think we pass that question to Prof. Khaldun.
The answer is that venom is mostly enzyme, and enzymes are made of protein. So if you eat, then you are just digesting protein like any other. It doesn't really cause much issue unless you have perhaps a very big amount, a big surface area of ulcer. Then the venom may cross over before breaking down. But otherwise, it doesn't really. Ingesting venom doesn't really cause much of an issue. Doesn't make you strong either. Maybe it does because it's protein, right? Yeah. Yeah. Okay. So I saw one more question. In case of a remote location and yellow lip banded secret, I think they are talking about Lepicauda colubrina, maybe sea snake, a secret. Bite is the priority access to AV or to intubation. Basic EMS services, because Corina Stitch. The answer is with all snakebite, it's all about indication. Why you want to intubate the patient, you must have an indication, whether it's pre-hospital or along the way to the hospital or even within the hospital. Okay, so you have to be trained well to identify all these indications to intubate the patient or not, and then to give antivenom. So antivenom is not given out of hospital. It's always in the hospital. Okay. For obvious reason, for safety and also controlled environment. And also obviously you don't want the antivenom to be exposed to the elements outside. And, we are in a hot country. Sometimes the antivenom can get into the sun and so on, that will will compromise the efficacy of the antivenom itself. So we give antivenom in the emergency department or in the hospital setting, not in the pre-hospital care. Okay. That's the general rule. Does it mean that we never give antivenom outside of hospital? Not 100% true either, because there are situations where we have remote situation where patient so far away and we responded with medical help. For example, in Malaysia, we had Sarawak. Sarawak is very remote area. So we did carry the antivenom when we are actually responding to cases in remote area with helicopter and so on. So the doctor need to give the antivenom there and then, but you need to know the risk of giving antivenom as well. So you have to be well prepared if anything happen, especially with the allergic reaction, and also continuous monitoring of the patient. Okay. So I hope that answered the question. Right.
Okay, thank you. So I think we have answered the question from the participant. So I would like to invite the speakers to have a final takeaway message. We start from Dr. Ho. Any final takeaway message?
So I still to promote the police protocol. This protocol can help the clinician to make a good decision and even can elevate the anxiety of the clinician, because maybe you think, oh, that's not good enough for my antivenom, or maybe I cannot identify the snake. So if you have this police protocol, it can help you to determine the dose of antivenom and the objective that the your patient's swallowing condition. I promote this policy. I also thank the Dr. Cao to help me to build this protocol. Thank you very much.
Okay, next, Dr. Hassan, it's your turn.
Thank you so much. I think I can't stress more on the idea of knowledge sharing. And I'm sure this is, if like just 10 years ago, we should have traveled to somewhere else to get this kind of discussion. But now it's just there in front of us. So thank you for the genius mind behind all this. And thank you to Dr. Professor Khaldun and his team. And thank you for everyone for sharing us your very valuable experience. I'm not assuming myself as someone into toxinology per se, but I'm really get interested into it. But I have a lot to learn about it. So for sure,
You in Cameron Highlands. You're gonna have a course, Sam and also MEP next month.
Yeah, hopefully, inshallah. So thank you very much. Thank you very much. Nice to meet you all.
Thank you, Dr. Hassan. Dr. Tri Maharani.
Yeah, solution is the neglected cases is education and education. Education with the training to hard worker, education with the guideline, education with the offline and online training, and many people in Indonesia also. I think education is the first solution about many things. The people don't know about the snake and the snakebite. And I hope my country, the many area and many island have the good education with the IT, because now IT is the solution. It's very fast, very cheap, and covering all my country, the area all my country. Thank you, Dr. Prof. Kal. From time I'm shared to condition Indonesia in the neglected case about Daboia. Thank you, Dr. Amirul also, and all.
So next is Dr. Simene.
Yes, thank you for inviting me. Final words. I hope we have this event, a really great and helpful event. And I know that there are many societies that are also snake lovers, because I believe that snakes also play a significant role in the ecosystem. But the people will really, the instinct is to kill the snake. Maybe it's because there is no readily available antivenom. But when we just do our research, snakes also play a role. No, it is a source of the antihypertensive meds, antiplatelet meds, no, anticoagulant meds. So maybe this network through Rex Philippines, and I hope we can do and promote networking to have this easy access of antivenom. At least if all the antivenom is available for a specific snake, then maybe the killing of snakes will be lessened. So I hope that will happen. Thank you for this event.
Okay. Lastly, Prof. Khaldun.
Okay, just say thank you to all speakers. I just want to answer one last question that was stood up. Transport the victim to nearest facility with no antivenom versus further facility with antivenom. The one you have to flip the coin. Obviously, if there's no issue with patient vital signs and so on, you can go for the nearest antivenom facility with antivenom. But if you don't, you can always transport the patient to the nearest facility for close monitoring, and you transfer the antivenom from the other facility to that patient. So we've done that also in Malaysia. Okay, we do not transfer patient, we transfer antivenom.
Thank you.
So that's the good thing when we have, as Rutchell said, the REX networking. We transferred antivenom from north of, from Kelantan all the way to Johor, because they don't have the antivenom at that time. So we did that. So it's possible. Okay, a patient is more safe in the facility which is in controlled environment, safer to transport antivenom rather than human, perhaps also cheaper as well. So you have to discuss among your system, your health system. For example, Maha, you have to wait until 2020 to really push the agenda of Daboia Siamensis, which we already know for a long time already. The limitation of antivenom in Indonesia. So we have to make Maha our next Minister of Health for Indonesia. Then maybe we can get all these things done. Sometimes it requires that. A lot of people who are up there are not aware about all these things that our patients suffer. So we have to bring it up and choose the best for our patients. Okay, so I think that's all for me. All the best again to all speakers. Thank you so much. Back to you, Amirul.
Okay. Thank you all panelists for lending your valuable time and sharing your expertise with us today. We are grateful to have you today. Now, we can turn our attention to the most awaited segment of the day, Kahoot session. A special prize is up for grab. So kindly open the Kahoot website via laptop or phone and key in the PIN number to log in. We will open the Kahoot registration for 3 minutes. Then we will start immediately.